Okay, in the interest of time, let's get started here. Welcome. Thank you for coming. This is our finale of our summer webinar series on the science of addiction with Dr. Seefeld and Matt Howe. Just a little bit of housekeeping here. If you can please mute your phone or computer if you're not a speaker, that would be wonderful. Submit all questions via the Q&A chat box, and I will read those for the speakers towards the end of the presentation. And if you have any questions, you can contact me. My information is here. I will also send out slides, and the recording will be uploaded to our YouTube channel. So just a little bit about my program. I'm the program coordinator for Central New Hampshire Community Opioid Response. Our mission statement is the Central New Hampshire Community Opioid Response Program aims to ensure comprehensive, coordinated, and easily accessible prevention, treatment, and recovery services for those impacted by opioid use disorders in the Central New Hampshire region. And our vision statement for the future is that we will build a community to treat and promote recovery from opioid use disorders. The program will create a local system that is free of barriers, easily accessible, and fully integrated at every point of contact to reduce opioid misuse and promote healthy lifestyles and promising futures. And our speakers today, if everyone could please mute their phones. Our speakers today are Dr. Seefeld, who is a board-certified emergency medicine physician practicing in Plymouth. He is the medical director of the emergency department and the director of emergency medical services and trauma services at Spear Memorial Hospital. Dr. Seefeld graduated from UCLA with a bachelor in science in psychobiology and a minor in anthropology. He attended Pennsylvania State College of Medicine, where he received his doctorate in medicine. Matt Howe has been the program director of the Plymouth House, helping countless clients over the past 12 years. He is a global speaker and lecturer, presenting workshops and talks on addiction and recovery in both Europe and the United States. He's a frequent guest lecturer at Plymouth State University. Matt is a registered nurse, certified drug and alcohol counselor, and holds degrees in psychology, philosophy, and nursing, and is currently training as a nurse practitioner. All right, so Dr. Seefeld, do you want to share your screen now?
Yes, let's see if we can pull this off. You tell me what you're seeing right now.
Perfect.
Awesome. I'm going to just see if I can pull up, because it's like talking to a blank. So I don't get to see people. So it's really, this is a real test. So thanks for having us on here, Tara. This is awesome. It's the science of addiction is near and dear to my heart, and I do a lot in recovery medicine. So I'm honored to share some of my passion with you. So addictions can be divided into three broad categories. Substance addiction, this is things like alcohol, cocaine, nicotine. Behavioral addiction, things like eating, gambling, sex, social media, enabling. And then emotional addiction, things like anger and anxiety. And what I'm noticing in the world of addiction medicine is that the emotional addiction usually predates the substance and the behavioral addictions. And this talk is going to be about the science of addiction, but what I see in my practice in the addiction world is when we address the emotional dysregulation and we get people emotionally sober, their substance and behavioral addictions aren't a thing anymore. So we really have to start attacking the emotional components to these problems. It's not just about not drinking alcohol today or not gambling today. It's about understanding the emotional context. So again, that's a much bigger conversation, and I'd love to have that conversation moving forward at some point, but today we'll stick with the science. So addiction is a treatable chronic medical disease involving complex interactions among the brain circuits, genetics, the environment, and an individual's life experiences. And what we're learning is life experiences, childhood adverse events, childhood trauma, things like that are really predictors of developing substance use disorder. So we're learning a lot more. It's not just genetic. It is the environment. It's what people are raised in. So it's much bigger than a molecule or a neuron. For the addict, the use of substances, and this can be food addiction or drugs or alcohol, you can put whatever you want there, or the engagement in certain behaviors such as gambling, sex addiction, things like that, becomes compulsive and continues despite harmful consequences. And to me, that's the line I draw in the sand. When people say, when's addiction a problem? It's when someone is using substances or engaging in behaviors that are causing maladaptation in their lives. It's affecting them negatively, it's affecting their loved ones negatively, and they're still choosing to do it, okay? And we'll drill more into the idea of conscious choice versus how strong the brain really wants that drug and whether the addict really even has an opportunity to exert self-control once the addiction has taken place. Prevention efforts, and this is optimism, right? Prevention efforts and treatments for addiction are generally as successful as those for other chronic diseases, such as diabetes, high blood pressure, things like that. So to understand addiction, we have to understand, how are we defining substance use disorder? And again, I spoke to behavioral addictions, emotional addictions. Understand that these are interchangeable. But for the purposes of this talk, we're going to speak about substance use disorder. Okay, and we classify that according to the DSM, which is a Diagnostic Statistics Manual. It's a manual that we use to diagnose illness. And mild, moderate, or severe. And I'm just going to list the criteria and we'll just kind of talk briefly about them. So there's 11 criteria. Hazardous use, kind of self-explanatory. Social interpersonal problems related to use. Are you not showing up to work because you're drinking? Are you not picking your kids up from school because you're out looking for crack cocaine, right? Neglected major roles to use. That can be kind of coincide with the previous one. What is a normal role that you would have in life, and now you're not doing that, right? A parent, a worker, things like that. The concept of withdrawal, which is the physiologic withdrawal. So this is when I don't take the drug, I get ill, right? The concept of tolerance. I need more of the drug or alcohol to get to the same point. That's the concept of tolerance. Use larger amounts for longer, kind of related to tolerance. Repeated attempts to control use or quit. And again, come hang out in the emergency department. I see a lot of the individuals that suffer with substance use disorder again and again, and I hear the same story. I really want to quit this time. And then we have the same conversation a month from now, That's a big one. Much time spent using. Physical or psychological problems related to use. Again, as an emergency department physician, I get a lot of patients that come in for, quote, depression or anxiety. And when you drill into what's really going on for them, they have untreated alcoholism. And when you treat their alcoholism or their substance use disorder, and you really attack the emotional components that predates all of this, guess what gets better? Their depression or their anxiety. I have numerous patients that have been on every SSRI on the market. They get well and they start doing the emotional work behind their substance use disorder. They don't take anything. That's not to say that there's not a role for antidepressants, anti-anxiety medicines. That's not what I'm speaking to. I'm simply making an observation in my clinical practice. Physical, right? What is the physical problems that's associated with substance use disorder? Alcoholics get liver disease. IV drug users put themselves at risk for hepatitis C and HIV. So there are risks, okay, physical and psychological. Activities given up to use. You talk to a lot of people in recovery and they tell you, I used to do all these things, and during my addiction, I did none of the things I used to enjoy. I used to be a skier. I used to, go camping. I stopped doing that. I was preoccupied with using drugs or drinking. If you have, and then craving is the last one. Craving meaning if you don't have it, you want it. In order to be diagnosed with a substance use disorder, you only need to meet 2 of these criteria over the 12 months preceding it. So only 2. So what I learned from looking at this slide is that we're underdiagnosing substance use disorder in our world. And there are a lot more people that meet criteria for substance use disorder that are being picked up, okay?
I'm listening to a webinar.
Awesome. So the disease model, everyone says is addiction a disease. So the traditional medical model of disease, this comes from the Medical Association, requires that an abnormal condition be present in a person that causes discomfort, dysfunction, and distress. Okay, that's those three criteria. Addiction is classified as a disease because it is a chemical or biological issue that is primary, it's progressive, it's chronic, and ultimately fatal if left untreated. Diabetes, fatal if left untreated, right? Hypertension, fatal if left untreated, right? Cardiovascular disease, fatal if left untreated. So it fits nicely in the disease model of addiction. So what was the past? I love this slide. So I'm a product of the 80s. I was born in '77. And I was told that my brain on drugs looked like this. Okay, and anybody who's a product of the 80s or before then knows what I'm talking about. It was an egg cracked in a skillet. And that's what I thought. So what is the modern day egg in a skillet? It's a PET scan. So here's our new egg in a skillet. So this is a PET scan image of human brains, and I'll put my little cursor up here for you. And what they did is they, radioactive cocaine was put into the person, and then they followed areas of the brain. And you can see the yellow here is where cocaine is activated. Now, again, you can replace cocaine with alcohol or other substances here. It doesn't matter. That's not the purpose of the slide to isolate cocaine. It's just using a model. But you can see how quickly it comes on, and it really has a strong effect here. We're going to learn that this is the basal ganglia, this is the midbrain, which is our reward center later on. And it's pretty fascinating. Around 10 minutes, it's already gone. And you can see that is how powerful this substance is. So to understand addiction, we have to have some basic understanding of the brain, okay? And understand that certain parts of the brain govern specific functions. If you've had a friend or know someone who's had a stroke, you can understand that different parts of the brain affect certain parts of life. And so here you have a motor cortex, okay? And that's movement. If I have a stroke or an injury to my motor center, I will have difficulty moving a part of my body. Here's your sensory cortex. If I have an injury to the sensory cortex, I'll have a problem feeling a part of my body. Here's your coordination, your vision, so on and so forth. Understand that each of these parts of the brain communicate with each other via neurons. Neurons are our basic unit of communication within the brain. And the process of communication between the neurons is called neurotransmission. So drilling deeper into what neurotransmission is, we have to have an understanding of what a neurotransmitter is. And to do so, we're going to look at this nice image here. So here's one neuron communicating with another neuron. And this is dopamine. Dopamine is one of the neurotransmitters. There's other, serotonin, norepinephrine, but we'll speak about dopamine here. So dopamine gets released in this area called the synapse. It then binds to a receptor on the next neuron in line, which then propagates the signal. Once that signal has been propagated, the previous neuron says, well, let me get my dopamine back up so I can then transmit the next signal when that comes. That's the reuptake process, okay? Now understand that drugs interfere with this process, right? Drugs can either block the reuptake, right? We have things called SSRIs for depression, serotonin reuptake inhibitors. It blocks the reuptake of serotonin. Cocaine blocks the reuptake of dopamine, so you have more dopamine in the synapse, okay? Drugs can also act as agonists, which means they can mimic the dopamine itself and bind to this receptor and propagate a signal that normally wouldn't have been propagated. Again, deeper than this talk, but just having an understanding that neurotransmitters are our unit of communication between neurons. Neurons are our ability to transmit stimuli from one part of the, or messages, excuse me, from one part of the brain to the other. So what are the big players, all right? You can sum up addiction. Again, addiction is a complex process. It's complex science here, but there's three major areas of the brain that we have now acknowledged that play a role in addiction. The basal ganglia, which is our reward circuit, the extended amygdala, this is part of our limbic system. This is our stress circuit. And then the prefrontal cortex. This is the neocortex. This is the part of the brain, the mammalian brain that makes us human. All right, this is higher order functions. So we're going to drill deeper into each of these. So the basal ganglia. It's a group of structures located deep within the brain that play an important role in keeping body movements smooth and coordinated. That's our brains, our cerebellum. And then motivation, it plays a role in motivation, eating, socialization, sex, and the formation of habits and routines. And understand that all these processes are in place to help us as a species survive. And as we spoke to earlier, is that drugs interfere with normal physiologic adaptive responses, right? So if I didn't have a mechanism in place, if the prehistoric man didn't have a mechanism in place in the brain to tell him or her to eat, to socialize, to have sex, they would not have survived, right? So that's normal physiology. Drugs, alcohol, things like this, they take over the normal physiology of the brain, and that's where the problems arise, okay? So the basal ganglia controls the rewarding or pleasurable effects of substance use, okay? And it's responsible for the formation of the habitual substance taking. This is why they continue to use the substance. And we're going to learn a lot more about the basal ganglia moving forward. But let's talk about the extended amygdala. This is our stress circuit. It's located beneath the basal ganglia, and it regulates the brain's reactions to stress. That's our fight or flight response. And negative emotions, unease, anxiety, and irritability. It is involved, just give me 1 second, my daughter is at home. Issa, can you turn that off? Sorry, that's just classic, right? We're doing homeschooling because of so this is me talking from my living room. Sorry, lost my train of thought for a second. So located beneath the basal ganglia, regulates the brain's reactions to stress, that's the fight or flight, and then negative emotions, your unease, your anxiety, and your irritability. Understand that these are the symptoms that people don't like, and so it's going to motivate them to get out of that psychological state, that physical state of unease, okay? So it's involved in the stress and negative emotions that typically accompany substance withdrawal, thus motivating the person to seek the substance. The prefrontal cortex. So it's located in the very front of the brain, and it powers the ability to think, plan, solve problems, make decisions, and exert self-control over impulses. It's involved in exerting control over substance taking. So understand that the prefrontal cortex, in our caveman days, right, before drugs and stuff, the prefrontal cortex serves a purpose. It gives us higher order functions. It allows us to exert self-control and not make choices that are maladaptive. Drugs interfere with the connections between these three areas, and as a result, you can see why someone with a substance use disorder might not exert self-control. They might use a dirty needle or engage in maladaptive behavior pattern that's putting them or others at risk without having conscious control over that. And this is that concept of choice. Once you become the addict, you really are losing control. The prefrontal cortex is now having different signaling as a result of what the drugs are doing, and it's stronger than what we would have done predating the substance use, if that makes sense. And we'll talk a little more about that as we talk about the reward circuit. So you can see that all three of these interrelate for adaptability, and drugs interfere with that process and make things maladaptive for the substance abuser. So you shift the balance between these three centers, and you can see why a person with an addiction can seek a substance or do a behavior compulsively with reduced impulse control. So the addiction cycle, and I kind of like this. It's understanding addiction is really a repeating cycle of 3 stages. There's the binge and intoxication stage, which is associated with our basal ganglia. We've already spoken to that. That's our reward, our pleasure-seeking section, right? So this is where somebody consumes an intoxicating substance. They feel good. They feel the pleasurable effects. And then we move into the withdrawal negative effect phase. This is your withdrawal phase. This is your extended amygdala. This is the uneasy feelings and the negative emotional states associated with the substance. And then after a period of abstinence, they move back into the preoccupation anticipation stage, which is our prefrontal cortex, which is the stage at which one seeks substances again and again after a period of abstinence. And so you can see, you know, someone does a drug, they enjoy it, they stop the drug, they have the withdrawal stage, and then the prefrontal cortex says, hey, let's go get that again, and it's a vicious cycle. The reward pathway. So to understand the reward pathway, we'll go back to talking about neurotransmission. When activated by rewarding stimulus, and I'll use my cursor here, such as food, right? That's a rewarding stimulus. It feels good to eat. Drug feels good as well. You have this increased signaling of dopamine neurotransmission from an area called the VTA, the ventral tegmental area, and it goes up to the nucleus accumbens. Okay, and that's in your midbrain. And the nucleus accumbens' only purpose is to measure the goodness of the reward. Okay, how good was that reward? So food is going to have a certain amount of dopamine release. Crack cocaine will have a certain amount. The nucleus accumbens is going to see which one's more dopamine and say, I want that one. Okay, it doesn't differentiate between the two. Okay, so once you have the nucleus accumbens measure the dopamine release, it then sends a signal up to the prefrontal cortex. Okay, and it uses glutamate this time, which is the neurotransmitter. And it says, remember the environment and the behaviors which were associated with this goodness, right? And then projections from the prefrontal cortex send signaling back to your midbrain, back to the nucleus accumbens, saying, go ahead and do these behaviors and do the behaviors that are associated with the higher dopamine release. And often those higher dopamine releases are going to be the maladaptive ones, such as crack cocaine versus food. And you can understand then why you can see a substance abuser, a drug addict, an alcoholic, where they're not doing normal, healthy behaviors, okay? They're subconsciously choosing to continue to use despite the consequences. Large surges of dopamine are literally teaching the brain to seek drugs or do the addictive behaviors at the expense of other healthier goals and activities. And this is one of my favorite slides. Food and sex. This gives you a measure of dopamine. And just look at the number here. It's not so much to understand all the specifics, but 150 is kind of the metric here. This is the amount of dopamine that's released with food. Sex goes up to about 200. So let's take a look at drugs. Methamphetamine goes up to 1100, right? That's a lot of dopamine. Nicotine above 200, cocaine above 350, morphine up there above 200. So the idea is that these substances are stronger. They are resulting in a higher dopamine release than normal learned behaviors such as eating, socialization, and sex. And this is why it literally is hijacked. Drugs have hijacked the brain's normal adaptive physiology and created this maladaptive environment. So, summary. Addictive substances and behaviors, you can think of cocaine and gambling, as well as normal learned behaviors such as eating, stimulate the same neural pathways. That's what we've been speaking to. Addictive substances and behaviors cause a higher degree of neuronal pathway stimulation and neurotransmitter release, right? We just showed that. More dopamine is being released. This increase in dopamine or increase in neurotransmitter release leads to changes in the brain's neurocircuitry responsible for sensing satisfaction and reward. That's our basal ganglia. So we are refocusing the basal ganglia onto drug use or alcohol or maladaptive behaviors rather than normal ones. I say normal, but adaptive ones like eating, socialization, things like that. Continued exposure to the addictive substance or behavior leads to repetition of the behavior. That's your prefrontal cortex saying, hey, do that behavior. I got a bigger dopamine release than the other one. And that led to the neurotransmitter in the release in the first place. And then the negative emotional states, that's things like anxiety and irritability. Those are withdrawal symptoms. And those are what the patient, or excuse me, the person is seeking, causing the patient to seek a substance or do the addictive behavior over and over again. And that's
What's the main ingredient in Adderall?
Okay. So I know that's a lot to throw at you, but it is the science of addiction. I started doing these talks about a year ago, and it's melded into what you're seeing today. And it's fascinating. Every time I continue to do these talks and stay up with the research, I learn more and more. It really is it's a fascinating subject. I do want to spend, and I don't know, Terry, you can let me know, I wanted to mention a virtual, first of all, the references. National Institute of Drug Abuse is a phenomenal resource. If you guys have any questions and things, I mean, it's a great resource. It's all free content. They've got lectures and stuff. So most of the images that I pulled all came from this website. What I was going to ask is, would it be appropriate if now I mentioned the virtual recovery community? Tara?
Yeah, that's fine.
Oh, perfect. Okay. So I just wanted to mention this. I know there's some practitioners on the call. We do have so I have a twin brother, he's in recovery, and he has developed a free app called My Lifelink. And this is a virtual recovery community that's supporting people throughout the world. And it's a free app. You can download it on the App Store or Google Play. You know, and the idea of recovery, you know, a lot of being in recovery or sobriety and having recovery has to do with community. And right now, community is very difficult. I'm giving you a talk that I would normally do in person. I'm doing this from my living room with my 13-year-old daughter, you know, doing virtual learning herself. So community has an asterisk next to it. And what I've noticed as an emergency physician is we've seen an uptick, not just in mental illness visits, but also in substance misuse and substance abuse related. And there's a lot more substance use disorder patients out there that we're not even picking up. And there's a lot more addicts out there that we're not picking up, because again, if you extrapolate it out to behavioral addictions and emotional addictions, you know, some people would argue that we all could be, you know, doing some of this emotional work. You know, there's a lot of people that don't suffer from substance use disorder or behavioral addictions who have maladaptations in life as a result of emotional addiction. Well, My Lifelink really is attacking the world of recovery at the emotional level. And so it's a group of people. I go on there often and do lectures on addiction and things like that, that are supporting each other in a platform that in the context of COVID is very adaptive. And there's lots of support. So I'd encourage, we have people on Lifelink that are friends and family of addicts who want support. And there's lots of different things. I'll let you guys take a look at it. But it's all, you know, you can be anonymous and whatnot, but it's a great community. And I think in the context of COVID, for sure, and a lot of less access to inpatient in-person meetings, you know, it offers a real good resource there. And then I will finish with Summit Health, and Matt Howe is my business partner. I believe he's on, so I'm going to stop talking. I believe I will let Tara take over and reclaim her screen if you want. I appreciate you guys showing up for me. Thank you.
Thank you so much, Dr. Seefeld. Yes. All right, Matt, you're up.
So great job. Andrew always does a wonderful, wonderful job with the science of addiction. My thought is we talk for just a couple minutes about our private practice we put together, and then take some questions on the content today, or how the content manifests pragmatically as behaviors. Andrew and I put together Summit about 2 years ago, and it's been a project of passion for us. We put together an interdisciplinary team consisting of medical treatment, psychotherapeutic treatment, behavioral support with recovery coaches, psychiatric services, and trying to develop community. And philosophically, we're coming at it. We sort of talked about it in the scientific technical terms in Andrew's presentation. We're coming at it from all of these different levels of analysis, focusing on the behavioral level. And it started as a side project, and we weren't sure if we were going to get any interest, and it's actually got to the point now where it's too much interest. So we're both dads, and I'm going to be I have another baby coming on Monday. So the approach has worked well in that we've had a lot of success, and we've had a lot of clients to the point where we're sort of maxed out, which is it's a nice thing and not a nice thing, meaning the fact that the need is there is certainly concerning, but the fact that we can help people is a good feeling. We're happy to take some questions if anyone has them.
Definitely. Okay. Let me just gonna flip back here so that everybody has my, all right. So just a quick note before we go into questions. We are going to be having a fall event. It's sort of a replacement for our kickoff events that were had to be canceled because of COVID. It's going to be called CNHCOR, that's Central New Hampshire Community Opioid Response, leading the way, and it'll be featuring Chris Sullivan, who some of you may be familiar with. He was a NFL player for New England and Pittsburgh, and has his own story of struggles with substance use and mental health and overcoming those. So that's gonna, you don't want to miss that. We will have the slides sent out and the YouTube channel recording posted by the end of the week. Our prior 3 events are up there as well. And for questions, so I can get to the chat. And if you just want to enter your questions in the chat box, I can read them for the presenters. Here it is. Okay, does this science support the use of medication-assisted treatment programs?
Sorry, what was, I missed the first part.
Does the science support the use of medication-assisted treatment programs?
Oh,
MAT.
Does the science support, I guess the question is what's the outcome we're looking for? You know, medication-assisted treatment is exactly that. It's medication that's mimicking often. It's like, look at Suboxone, right? Suboxone is an opiate. It binds to opiate receptors. It's doing the same thing to the brain that other drugs are doing. We just looked at that. And so I guess it's the outcome we're looking at. What are we measuring? I guess it also depends on what we define as recovery, you know? So that's a whole nother conversation to have.
Mm-hmm.
Yeah, Matt, I don't know if you have something on that.
Yeah, I mean, my prediction is that would certainly be a question someone would ask. It's as everyone knows, it's a heated issue. Suboxone has been around for over 20 years now. I think that Andrew hit it right on the head. We'd have to do a concept analysis on recovery and a concept analysis on treatment. So I think that there are people for whom medication-assisted therapy, specifically Suboxone, works so long as their definition of recovery is being adhered to. As to whether the science supports it, again, you'd have to define your terms as to what success is. If your definition of success is this person remained abstinent from other drugs or illicit drugs from 6 months, there's certainly some literature that says yes, while this person underwent mid to long-term Suboxone maintenance therapy, they remained abstinent. What we're doing is a different modality, so we're not, if people come to us specifically, the work that Andrew and I do, and say, hey, do you do Suboxone? We don't, and we're not anti-MAT by any means. We just don't do it. It would be as if you were approaching a psychotherapist who works with cognitive behavioral therapy and asking them to do psychoanalysis. They're probably not anti-psychoanalysis. It's just they're coming at it from a different angle. So our definition of recovery, as Andrew had discussed earlier, is emotional sobriety, stability, maximizing human potential. And that's not to say that you can't do those things while you're utilizing Suboxone. It's just, for me personally, the literature that I've seen, the definition of recovery tends to be a little bit narrow.
Thank you. Wendy asks if there will be a follow-up to this presentation, or maybe a more in-depth scientific presentation. Do you do any of those, Dr. Seefeld?
I have an excellent, I say excellent, I've been told it's a good one on post-acute withdrawal syndrome. And that's one that I think the world really would benefit from seeing and understanding, that when we take away the drinking or the drug, that's just the beginning, right? And up to 2 years, the brain is healing, and it's going to come with, you know, waxing and waning periods of emotional dysregularity, and it's okay to feel those feelings. And I feel it. I would say that in my experience, half the battle is truly understanding what's going on in our brains, you know. And this is like the LifeLink app, you know, these talks that I do, and I support the community, and we all support each other, and it gives insight into what to expect for someone who's day 14, right? They're out of the acute withdrawal phase, which is the physiologic withdrawal phase, and now they're into what I consider the psychological maelstrom, right? The neurotransmitters are healing. And I always say think of a laceration. If you come see me with a cut on your arm and I suture it up, and you come back on day 2 and say, can you take these out, doctor? I'm healed. And I take them out, the wound's going to open back up. It takes 10 to 14 days for an arm laceration to effectively heal. Well, the brain, depending on how long you've been using, you know, a substance and how frequently and how much, it's going to take time. And I think the more we understand about that, there's going to be less stigma, right? And I also, you know, so I would say the sky's the limit in terms of discussions. I am not a neurophysiologist. I will never pretend to be one on TV. So full disclosure, I think this, where I'm at in terms of the science of addiction, this is where my growth has been. I'm certainly, I'm continuing to look, but I think in terms of opportunities, there's a lot out there.
Definitely. We'll keep that in mind to tap you for that, for another one, maybe. Yeah. Are the handouts available showing Dr. Seefeld's slides? So would you be able to send me your slides to send out to people? Okay.
Yeah, and again, the asterisk there is that, you know, the images were taken from the NIDA set, the website and stuff, and they have no problem with reproducibility. Yeah. So
great, thank you. Let's see. Are there significant differences in incidence or prevalence for addiction based on age, i.e., are adolescents more likely to be headed towards addiction because of their brain development?
Which one was this? I got to read that again. Read that to me one more time. Or Maddie, if you caught that, maybe you can chime in.
Yeah, Tara, could you read that just one more time?
Sure. Are there significant differences in incidence or prevalence for addiction based on age, i.e., are adolescents more likely to be headed towards addiction because of their brain development?
So, again, Andrew did such a great job in the presentation around how this is multifactorial, which I think is super important. It's overly reductive to say, hey, this is just your genes, or this is just your biology. We're also looking at the context in which a human life takes place. So trauma was, I don't want to say ignored, but it wasn't in the mainstream until recently in recovery circles. So I've been doing recovery for a very long time, and find in my circle just recently, we're really starting to look at the importance of childhood trauma, especially younger children, adolescents, because you've got this really malleable, fragile brain, and also this really malleable, fragile psyche. When someone is sort of in this place where, and trauma is a broad term, so a lot of people think of trauma as, oh, it had to be some massive event. No, trauma is a negative event that sort of creates a groove and a pattern in your psyche and in your brain. And the brain and the human mind is exquisitely sensitive to negative experiences and negative emotions. We are far more sensitized to negative emotion than we are positive emotion, which makes sense. Evolution has programmed us that way because evolution doesn't really care if you're happy so much. It just cares that you don't die so you can procreate. So negative experiences, you know, our threat sensing system, which is really fast but really dumb, sees everything as a tiger about to eat us. Mm-hmm. And it doesn't matter if it's perceived or real. You know this if you have a phobia. getting on a plane is relatively safe. It's safer probably than your drive to the airport. But if you have a phobia of flying, that threat sensing system is saying, this is a tiger that's going to eat us. Let's get away from it, because it doesn't know the difference between that and an actual predator that's going to end your life. Mm-hmm. So trauma happens, we experience it as negative, it sort of tattoos our psyche and says, this is a legitimate threat. And of course, it may have been a legitimate threat, or it may have been other threats that weren't a threat to your life, but certainly to your emotional security. What we want to do is resolve the threat. We want to get away from the tiger. So this childhood trauma, we formulate behavioral patterns. We're not conscious of it. That gets us away from the tiger. It gets us away from the tiger. When we get away from the tiger, we get a little bit of a reward. The reward sometimes is it's just the relief of that tension and anxiety. But that very fast part of our brain thinks, okay, you successfully got away from the tiger. But our anxiety is heightened. Our tension is heightened. We've got all of this predictive anxiety. So now you've got an adolescent mind or a younger person's mind who's sort of primed for heightened threat sensing. Alcohol, opiates, as Andrew said, they do a really, really great short-circuiting job of alleviating the anxiety, the tension, the depression, and those fast parts of our brain perceive that as you got away from the tiger. They do a really great job. I mean, alcohol and opiates are really, they're really, really good at what they do. They're really, I say this to clients all the time, opiates and alcohol, benzos, they're really excellent short-term problem solvers. They're great. They're maybe the world's best short-term problem solvers. You're depressed. Harris is mad. I'm anxious. I'm depressed. I give you an opiate. You're going to go, I feel terrific. Let's have a cigarette and take a walk. It's a terrific short-term problem solver. It's just a disastrous long-term tactic. It is absolutely disastrous because, as we all know, you get diminishing returns and the cost goes up. And I don't necessarily mean the monetary cost, although that is one aspect. It's all of these other consequences, my physical health, my relationships, my emotional, spiritual, psychological health. So when we're sort of primed for that sort of trauma, usually we start with behavioral addictions or with unhealthy coping mechanisms, things like avoidance and dissociation, which I see in not just in men, but a lot of the guys that I work with are dissociative and they're in their 40s and they tell me things like, hey, I'm lonely. I'm lonely all day. Even when around my children, I'm lonely. Why am I lonely? And it's this dissociation happened in childhood via trauma. Dissociation's a really, really good short-term problem solver, meaning it will get you away from things. The problem is, of course, you're not dissociated from everything. Mm-hmm. Here's where some of the genetics comes in. If you are predisposed, if you're sort of wired to get a really good response from cocaine, alcohol, opiates, and not everybody is, the vast majority of the world, keep in mind, almost every single person you know has been high on an opiate. Outside of newborns, everybody you know has been high on opiates. Even your grandmother has been high. Your grandma went in for a hip replacement. She left with 2 weeks of Dilaudid. She was exquisitely high for 2 weeks. But if she wasn't primed, if she wasn't sort of wired for that, genetically, if she didn't get this euphoric response, or if it didn't work to alleviate stress, and also if she wasn't in a place in her life, because this is very important, if she had positive human connections, if she had a sense of purpose and meaning in her life, if she had those things, then probably when the 2 weeks of Dilaudid ran out, she wouldn't be in a parking lot looking for heroin. Like most people, when the pain subsided and there was no legitimate need for analgesia, they put that bottle, and anyone who's an opiate addict knows this, you open up a medicine cabinet of a person who's not an addict, you're amazed to find Tylenol with codeine. 3/4 of the bottle is still there from like 1994. And that is the overwhelming majority of people. They can take it and leave it, and it's a tool for them for some pain relief, but it's not magic. Whereas if we're sort of primed, and that can just be through biology, oftentimes I find it's through trauma, or it's through adverse life conditions. I'm depressed. Someone passed away. I lost a job. I'm reckoning with the strife of just being a human being. I'm primed to get relief from that. And it works tremendously well in the short term. So I find a lot of this can go back to trauma, childhood, adolescent trauma, not all of it, but certainly a lot of it. That reward system that we're talking about, we need rewards. And roughly speaking, we've got two reward systems, the dopaminergic and the serotonergic. And the serotonergic, basically, it's an oversimplification. It tells you, okay, chill, everything's okay. And the dopaminergic is the feel good. It says, keep going for that. Keep going for that. And we need, as Andrew said, we need both of them. If we didn't have them, then our ancestors would have been lazy. They wouldn't have been motivated to get up out of the sun and find food and shelter and procreate, and none of us would exist. So these basic drives, they're important. They motivate us. And in fact, on a spiritual and psychological level, we need to be moving towards something. We are meaning and purpose seeking creatures. And without meaning and purpose in our lives, we sink quickly into despair. We sink into despair. And when we sink into despair, we regress to an earlier psychic state, the state of the infant ultimately, which means the future disappears. We become myopic. And when you don't care about the future, what happens, Viktor Frankl wrote about this, Freud wrote about this, is we start to prioritize short-term pleasure-seeking activities with no forethought to the future, which is a good way of describing being deep in alcoholism or drug addiction. I have a court appearance at 2, but I drink at 9 because the future isn't there because I'm deep in that despair. So that was a lengthy, verbose answer. So, but I hope it circled around the question, possibly.
That's great. Thank you. What is the logic of theory to replacing the reward of the addictive drug? A fair percentage of people seem to be able to overcome the addiction without support. And how do you explain this given the high reward of the drug?
A lot of this is neuroplasticity. It's the idea that I can reshape the brain, right? And again, this is the treatment for substance use disorder, and I believe this is what the question's speaking to, is emotional sobriety. And understanding the emotional context that you were drinking and drugging yourself to death in, that will prevent you from drinking and drugging yourself to death. And I see this in real time with people doing the emotional work. So that's the rewards, reshaping. It's reshaping and making connections that may never even have existed between those areas of the brain. It's called neuroplasticity, and that's a thing. And we have the ability to cognitively restructure our brains, but we have to be sober first, right? If we're alcoholic, we have to not be drinking alcohol. If we're a drug addict, we have to not be taking drugs. Right? If you're a behavioral addict, you need to stop, engaging in maladaptive behaviors like gambling or sex and things like that. If you're a food addict, understand that food addiction the brain doesn't see it any differently. If you are suffering with food addiction, that's the same as cocaine, right? Yes, the consequences are different, right? But are they? Food addiction, diabetes, early loss of life, loss of limb, vascular disease, cardiovascular. There's lots of consequences to these. So that's really, maybe Matt's got a clear answer to that, but really attacking the emotional sobriety, there's the solution for addiction in my mind.
And with, again, Tara, reward is a really amorphous concept. So what that looks like at the Plymouth House, we get folks who are here for about a month, and the way I sort of phrase it is people get here, they feel bad, which is appropriate. You're in residential treatment. You probably had a number of consequences that got you in this place. You miss your children, you miss your dog, you're post-acute withdrawal, so physically you don't feel good. The drugs and alcohol are gone. We also hear we don't have internet, so there's no binge shopping on Amazon. There's no Netflix binging. So we take away all of these other sources of addiction. People don't feel good, and they come to me and they say, I don't feel good. And my answer is, well, that's appropriate. And of course they don't like that answer, because what they're really asking me is, how do I feel better right now? And ultimately there's no way to feel better right now, but that's okay. So I explain it to them as a gauge. When we're in the midst of active addiction and alcoholism, our primary gauge is how we feel. That's the one that we always care about. If I'm in the midst of active addiction, you ask me how the world's operating, depends on how I feel. Everything is about how I feel. What we've got to do, especially in early recovery, is switch the gauge. The gauge can't be how I feel, because you're not going to feel good for a while. So we need to find another metric to measure how my day is going. The one that I encourage them, a few that I encourage these guys to use here is, did you meet your goals? Have you adhered to your principles? At the end of the day, can you look yourself in the mirror and say, I did everything I could do for my recovery? It's the difference between a track car and a passenger car. In a passenger car, your primary gauge is a speedometer because that's what you care about, not getting a ticket. But on a track car or a sports car, the primary gauge is the tachometer because you don't necessarily care about your ground speed. You care about what the engine is doing. So for folks who are here, I say, you've got to find a new gauge for now. And that gauge, again, a really good example of a replacement gauge is, did I make progress with my life? And if you do that, you can get to the end of the day, and this is a mind-blowing concept for a lot of the folks that I work with, is I could have a good day even though I didn't feel good. Even though I didn't feel good. I could have felt bad physically. I could have been sleepy, tired, depressed. But at the end of the day, if my gauge was, did I do what I needed to do? I had a good day. And so when you're talking about spontaneous recovery, people spontaneously recover. And I think there's a sort of a categorical difference between what we call alcoholics and drug addicts and people who got in a little bit too deep, but hadn't crossed that fuzzy line to where they lost executive control. And that's plenty of people. I know plenty of people who did that. You've also got other people who do cross the fuzzy line and they sort of put together their own recovery program. They start to jog, they do yoga, they join a church, they adopt a rescue dog. And what they've sort of done is develop a sense of purpose, meaning, structure in their life. And they put together their own recovery program. And they may not call it a recovery program, but plenty of people do that. For those that really cross the line, as Andrew illustrated so nicely, that becomes a problem because we lose the power of choice. So we don't have executive control anymore. And I've had more clients that I could ever count that have said to me, well, I don't want to drink, so I'm making a choice to not drink. And they legitimately have lost the desire to drink alcohol. They just don't have the executive control. It's as if I said, I'm making a choice to run a marathon today. I may have the desire to run a marathon, but I'm not in physical shape to do it. So it's no longer a matter of choice. Now, if I trained this year and ate right, I may have the ability a year from now. So I tell clients, it's not a matter of choice, it's a matter of ability. If you do a lot of work, you could develop the ability to not drink through changes in lifestyle, exploring your faulty tactics now, employing healthy coping mechanisms and behaviors, etc.
Okay, thank you. Where can we find the post-acute withdrawal syndrome talk? I don't know if you have that recorded anywhere, but I think we can look at bringing that to a future webinar. What are some approaches you use to address emotional addiction, depression, anxiety, etc.?
Yeah, I mean, and that's really kind of what we, emotional addiction. I mean, there's lots of different ways to get into, 12 Steps does an excellent job of bringing people into the idea that the problem really is them, right? It's the thinking, right? The self-awareness, that's a fantastic cognitive behavioral process to do a 4th step. There are lots of other modalities, and I won't spend the time speaking to them at this point, but understanding that emotional dysregulation, emotional addiction is the source for the feelings that have predated the use of substance, what Matt was speaking to, which was, why do I need to drink today? Why do I need to take a drug today? Why do I need to incessantly look at Facebook every 4 minutes? Why do I need to eat 15 cookies and I can't just have one, right? That's a deeper seated emotional process that needs to be addressed. And there's lots of different ways to get into the work. If like I said, the virtual recovery platform that we are developing with My Lifelink, that attacks the emotional component. It goes after that, it broadens you. And there's lots of different transformative thoughts that go into it. And again, that's for a different conversation. You guys can reach Tara, give everyone access to my information, and I'm happy to have a conversation at any point about recovery. It's near and dear to my heart, and Matt, I think I can speak for him as well.
Yeah, absolutely.
Passion of ours. It's deeper than an occupation. It's a passion. It's important for us to stay in this conversation for our own well-being.
Great. Yeah, when I send out the slides, I'll include your contact information. Looks like I have two more questions here. One, in regards to COVID-19, what was your perspective of the government closing everything early on in COVID, but essential operations kept liquor stores open?
Oh, that's an awesome question.
Good question.
As an ER doctor, I said to myself, if we closed all the liquor stores, I'd see an uptick in the alcohol withdrawal, right? So it was almost like self-preservation. I do find it ironic that, a deemed necessary process is alcohol and liquor. I think it speaks to how many people in the world require or use alcohol to, calm themselves down or to change their emotional state, not making any of them wrong. It's not wrong until you have negative consequences and then you're still drinking, right? That's what we spoke to at the beginning of this talk. Normal people can have a glass of wine. My girlfriend can have a glass of wine. That's awesome, right? So.
Yeah, and I know it's cliche to reference Huxley and Orwell, but you really can't help think of that. Like, well, we have to make sure people get their victory gin. We'll keep them calm and sedated for a while. That's a very good question.
Great, thank you. And the final question here, when somebody comes into the ER with opiate addiction, what help are they given beyond acute presentation?
Well, I'd say anyone who comes into the ER with an addiction, if I'm working, they have access to a lot more. And I'm not putting myself on a pedestal. It's just that this is a passion of mine. And so I will spend that extra effort, so to speak. I can't extrapolate that onto all the other emergency providers. It's not in the bandwidth right now. Matt and I are actually currently, we started to talk last week about developing a process. We're going to do it at our local emergency department where I'm director, and maybe extrapolate that into what an emergency department would have in terms of recovery options for people using things like My Lifelink and actually onboarding patients. Number one, screening patients more effectively with a few more questions to pick up those substance use disorders, right? And then having a process in place where we can onboard people into a recovery community rather than hand them a piece of paper and saying, hey, call this number, maybe you can get some help. We have a fantastic recovery community in Plymouth, New Hampshire. We are very fortunate here. As a result, I have lots of men and women that are always willing to help another struggling alcoholic or someone with addiction. That being said, trying to put that process into place formally and doing it, so that administration and whatnot is okay with it can take a little bit of time. But it is definitely one of my cornerstones of taking over as director is making sure we have a more effective means of giving help to the struggling patient with a substance use or even behavioral, addiction problem. And you can extrapolate that into mental health as well.
That's great.
Yeah.
And it is 1 p.m. on the dot. That was perfect. So as I said, I will send out the slides, and I will send another email when the recording is uploaded to YouTube. I'll send out everybody's contact info. And if you can send me those slides, I'll merge them all into one to email out in a PDF to everybody. And I believe that's it. We got through all the questions. So thank you so much, Dr. Seefeld and Matt.
Thank
Wonderful,
you.
as always, and I'm sure we'll be in touch soon.
Awesome.
Absolutely. Thanks for having us. Thanks, everybody.
Tara,
Thank
I'll
you.
let my daughter know that I'm grateful that she decided to distract us during the recording.
It's
She'll be-
absolutely fine. I think everybody
This is-
understands at this point.
I was going to say, it's perfect in the context of COVID, right?
Yes, absolutely. I've had my Great Dane bump into them.
Nice.
So yeah.
All
Have a
right,
good day,
guys.
everyone.